also leukocytosis, which means increased white blood cells, and this is also a sign of inflammation. So the minor criteria are all signs of inflammation, but they attract our attention that this patient might have rheumatic fever. So we have to have at least one major criteria with two minor criteria, or two major criteria in order to diagnose rheumatic fever. This is the subcutaneous nodule. This is a nodule under the skin. So this is subcutaneous nodule. This is the erythema marginatum. As we said, it is red at the periphery. So it is red at the periphery and pale in the center. So that's why we call it erythema marginatum. Now we start with the heart affection. And the heart affection, as we said, affects all layers of the heart, pericardium, endocardium, and myocardium. We start with the pericardium. Pericardium, this is the serous sac around the heart, and it is composed of two layers. The visceral layer, which is directly covering the heart, and the parietal layer, which is present near the chest wall. So we get fibrinous pericarditis. Pericarditis means inflammation of the pericardium, and fibrinous because it is rich in fibrin. So there is a lot of fibrin in the exudate that develops in the pericarditis caused by rheumatic fever. This fibrin will deposit on the visceral layer of the pericardium and will cause its appearance as irregular, shaggy appearance. This is the fibrin which is deposited on the visceral layer, and this fibrin will make the two layers, the parietal and visceral pericardium, are adherent together. So if we want to separate them from each other, we get an appearance and the feeling like if we have two pieces of bread and butter in the middle. So if we try to separate the bread from each other, it will cause a shredding of the butter and the bread. That's why we call this appearance as bread and butter appearance. So as we know that the pathologists are always looking for morphology, for the changes in appearance. So they connect everything to what they know. So this, the presence of fibrin and the trial to separate the visceral from the parietal pericardium with the shaggy appearance and the feeling that we feel, let them say that this is like bread and butter appearance. As we see here, this is the microscopic picture. We see that there is swelling, edema in the pericardium, and the fibrin is deposited on the surface. Then a fibrin network is deposited on the surface of the visceral pericardium. As we move to the myocardium will be affected also by rheumatic fever, and we have rheumatic myocarditis, inflammation of the myocardium caused by rheumatic affection. And this is this causes a characteristic lesion, which we call the Aschoff nodule or Aschoff body. The Aschoff nodule or Aschoff body. What's the Aschoff nodule or Aschoff body? This is inflammation that is present in between the muscle fibers, and it is present around blood vessels, perivascular in the connective tissue in between the myocardial bundles. This inflammatory infiltrate is composed of monocytes, lymphocytes, plasma cells, occasionally you can get a few neutrophils, but neutrophils are not characteristic of this inflammatory reaction. And there is fibrinoid necrosis in the center. So it is composed of inflammatory cells, lymphocytes, plasma cells, and fibroblasts, and fibrinoid nucleus. Besides, there are two characteristic cells. These are the aneuchomyocytes, which is a myocyte that is degenerated and has a bar-like nucleus, and an Aschoff cell, Aschoff giant cell, which is a small giant cell, which is present also in the reaction. So we have the Aschoff giant cell and the aneuchomyocyte, which is a degenerated myocyte. And these are present in around the blood vessels in the area, in the connective tissue in between the myocardial bundles. Okay, so this is another photo showing the Aschoff nodule here in between the muscle bundles and the connective tissue, and this shows the fibrinoid necrosis in the vessel and surrounded by the inflammatory infiltrate, causing the Aschoff nodule or Aschoff body. Now we get to the endocardium, and as we know, the endocardium is composed of two components. The valves of the heart are part of the endocardium, and the endocardium covering the inside of the heart, covering the atrium and ventricle from the inside. So if it is, if there is inflammation of the endocardium covering the chambers of the heart, we get some inflammatory infiltrate, and we get some areas where the inflammation heals by fibrosis and causes a white area, a white scarred area. This is called the milk patch, and it is this is called the McCallum's patch, and it is present usually in the left atrium. And the most affected parts of the heart will be the left atrium and the left ventricle. We get also inflammation of the valves, and the valves are also affected in order. The mitral valve between the right atrium and the left atrium and the left ventricle, between the left atrium and left ventricle, is the most affected, followed by the aortic, the tricuspid, and the pulmonary at the end. The valvular affection will be inflammation of the valve, rheumatic valvulitis, and it starts as an acute valvulitis where the valve is swollen and red, and then we get what we call the vegetation. And if you remember from studying thrombosis, we call the thrombus that develops on the valves of the heart vegetation, and it is because it looks like a small plant on the surface of the valve. So they call it vegetation. These vegetations are thrombi, small thrombi that are caused by, composed of platelets and fibrin. And it is present on the surface, the atrial surface of the valve, and they are present 1 millimeter from the margin of the valve. This is the margin of the valve, and it is present just away from the margin because this is the side where the valve closes, So this is the site of friction, which will cause injury of the endothelium, and then the thrombosis will be present. The thrombi in cases of rheumatic fever are small. They are firmly attached to the surface, and firmly attached is very important because this means they do not detach and they do not cause embolism. They are multiple, and they are present on the, in case of the mitral valve, on the atrial surface of the valve. So the valve is edematous, swollen, red, and there are vegetations which are small thrombi present on the surface towards the atrium, and they are firmly adherent. Also, there is inflammation in the chorda tendini, which connects the valve cusps to the wall of the heart, and they are also swollen and inflamed. As we go with several attacks of rheumatic fever and the chronicity of the disease, the valve becomes scarred and fibrosed, and the chorda tendini become shortened and thickened, and the valve becomes irregular and rough, and the vegetations are present as multiple vegetations on the surface towards the atrium, and they are present in a row, as we said, just 1 millimeter away from the margin of the valve. This will cause complications because as the valve becomes short, the chorda tendini are shortened and the valve becomes irregular and thick. It does not close well. So it causes as it closes, it might be not closing very well, what we call mitral regurg or valvular regurg or valvular stenosis. It either has regurg, so it's not closing very well, and the blood can pass back from the ventricle to the atrium, or it is closing very short, very tight, and causes stenosis, so the blood cannot pass easily from the atrium to the ventricle. And in both cases, it is causes a lot of harm to the patient. So this is the valve from the atrial surface. So we can see this is the valve, the normal valve, and the normal valve as it closes. And here the affected valve became irregular and with shortened cusps, and it does not close very well. And sometimes also we get calcification. As we said, as we know, calcification occurs on degenerated and necrotic material. So these are degenerated areas of the valve and where calcification is deposited. So the calcification will add to the harm and morbidity of the valve. This is a picture that shows the vegetation on the surface of the valve, and this is the vegetation. Here are the vegetation, and as we said, it is it is present about 1 millimeter from the margin of the valve where the closure occurs. The closure does not occur at the margin exactly, but a little bit away from the margin, so that it closes very well in the normal valve. This is another photo that shows regurg, which is mitral regurg, where the blood, when the mitral valve closes, gets back into the atrium again, because it does not close very well. Or it becomes stenosed and the blood passes slowly from one chamber to the other. It does not pass smoothly, it passes slowly as drops. It does not pass easily like here in the normal mitral valve. It passes as drops of blood from the atrium to the ventricle. So this is the most dangerous and the most harmful effect of rheumatic fever are the valvular changes, whether the valvular deformity, whether stenosis or regurgitation. All of them are cause harmful effects on the patient and may cause harmful effects on the function of the heart and may lead to heart failure later on. What are the causes of death? As we said, there is harmful effects on the valves, and which may cause heart failure. It may cause rheumatic. It may cause a back effect on the lungs and causes pulmonary hypertension. May cause secondary infection on the heart, on the affected valves, and may cause secondary infective endocarditis, which will have marked and harmful effects on the heart. That's about rheumatic fever. We have to remember few things about rheumatic fever. As we said, it's an immunologically mediated disease, so we don't find bacteria in the heart or in the affected organ. It's only the antibodies that are present that causes harm by cross-reacting with the antigens of the heart, muscle, and endocardium. We have to remember that it affects multiple organs, like the brain causes chorea, the skin causes subcutaneous nodules, it can affect the joints and causes polyarthritis, affecting large joints with migrating arthritis, and it can cause erythema marginatum, and above all, it affects the heart and causes pancreatitis, pericardium, endocardium, and myocardium. The pathognomonic lesion in the myocardium is the Aschoff nodule, and in the endocardium is the valvular lesion with the effect of stenosis or regurgitation of the valves. So remember all these about rheumatic fever. Now we go to the endocarditis, which is, as we said, the endocarditis is inflammation of the endocardium. Here we mean by endocarditis the valvular lesion. Endocarditis mean valvulitis here. So we have infective endocarditis. And the infective endocarditis, we divided into subacute infective endocarditis and acute infective endocarditis. Both are infective, so there is bacteria here in the valve. So in the valve here, we get to see the bacteria. And the difference between both of them is in the type of bacteria that affects the valve. In case of subacute bacterial endocarditis, we get infection of the valves by a low virulent bacteria, which is called Staphylococcus which are present in the as bacteria which are present in the mouth normally, and when there's a tooth extraction or something, it can pass into the circulation and affects the endocardium. It does not affect a normal valve. It only affects an already diseased valve, so it's only present in patients who have rheumatic valvulitis. So the chronic valvulitis is present, so it affects more by infective endocarditis, or in cases of congenital valvular disease or congenital heart disease. So it's already an affected valve, and it can cause infection and causes infective endocarditis by these low virulent bacteria. The acute bacterial endocarditis is caused by virulent bacteria like Staphylococcus aureus, and it does not need any disease in the valve. It is an already virulent or strong bacteria that can affect normal valves. So both of them whether subacute or acute endocarditis, infective endocarditis, will cause fever and will cause affection of the valve. And as the valve is mainly formed of endothelium, the endothelium with the inflammation will be injured, and this will cause the formation of vegetations. In case of acute and subacute bacterial endocarditis or infective endocarditis, here the vegetations are large and they are formed of platelets and fibrin and colonies of bacteria. And the colonies of the bacteria which are present in the vegetations of infective endocarditis will make the vegetations loose, and so they can cause emboli. They can be detached and cause embolism. So it is here they are loosely attached to the valve and they can cause embolism. So embolism is a characteristic or the characteristic complication of infective endocarditis, whether subacute or acute. يبقى acute bacterial endocarditis is caused by high virulent bacteria and can affect normal valve. Subacute bacterial endocarditis is caused by low virulent bacteria and only affects a diseased valve. Both of them cause the formation of vegetations on the valves, and these vegetations are large and they are invaded by large number of bacteria, and so they can be detached. They are loosely adherent and they can be detached and cause embolism. However, the emboli in cases of acute bacterial endocarditis will be septic emboli and will cause pyemia. So infective endocarditis, detached vegetations will cause pyemia. In cases of subacute bacterial endocarditis, the bacteria are of low virulence. So here the emboli will act as if they do not have bacteria and they will cause infarction only. The bacteria are so very low virulent that it cannot cause pyemia and it cannot cause abscesses and in the area where they settle. They only cause cut of blood supply and infarction. Also, the bacteria in cases of subacute bacterial endocarditis, when they they go to the kidney. They cause many areas of petechial hemorrhages on the surface of the kidney, which we call petechial hemorrhages, and this will give an appearance like as if the kidney has been bitten by a flea اللي هو البرغوث. That's why they call it flip bitten kidney, because it has all these small petechial hemorrhages on the surface, which are caused by these by the emboli of that reach the kidney. So they cause these petechial hemorrhages, and it is called flip bitten kidney, as if a flea has caused biting of the kidney. They cause also splinter hemorrhages under the nails, which we see here. These are called due to microemboli that reach the underneath the nails and cause splinter hemorrhages. So in cases of infective endocarditis, it causes pyemia and septic emboli, and will cause pyemic abscesses in different organs, and it causes systemic pyemia. In cases of subacute, the bacteria are of low virulence. It cannot cause pyemia. It causes only infarction in the areas where it goes, and it can cause some petechial hemorrhages, either under the nails where we get splinter hemorrhages, or in the kidney where they cause flip bitten kidney. They can also cause mycotic aneurysm, and this mycotic aneurysm can occur in the if these emboli pass through the vasa vasorum and settle in the wall of the vessels. They cause low-grade inflammation in the vessel wall, and this heals by fibrosis, and then this becomes a weak point and causes small aneurysms, which we call mycotic aneurysm. And don't mix mycotic aneurysm with fungus, because everything about the fungus we call mycotic. This is not caused by fungus. It's only caused by the low virulent organisms that can cause fibrosis in the wall of the vessel and small aneurysm. Can also cause subcutaneous nodules, which we call Osler's nodes. This was also a complication of subacute bacterial endocarditis. As we said, acute bacterial endocarditis will cause systemic pyemia, and it will cause multiple pyemic abscesses in all organs where they settle. And as we said, both of them will cause the presence of large vegetations, which are invaded by colonies of bacteria. These are the colonies of bacteria, and this is the vegetation. As we see, it is invaded by a large number of bacteria and inflammatory cells. So this is about rheumatic fever and endocarditis. I think we'll stop here, and then we can continue the next time. And if anyone has any question, you can ask me. اوكي، في حد عنده اي سؤال؟ ولاد انتوا سامعيني؟
يا دكتور سامعين حضرتك.
طيب في حد عنده اي سؤال؟
السلام عليكم دكتور.
اتفضل.
دكتور شو الفرق بالفالفيلايتس من السب اكيوت فيجيتيشن والاكيوت فيجيتيشن؟
I'm sorry. تاني.
شو الفرق بين الفيجيتيشن بالسب اكيوت endocarditis والاكيوت endocarditis؟
So there is no much difference in the vegetation. Both of them cause large vegetations. The vegetations are composed of platelets, fibrin, and bacterial colonies, and of course inflammatory cells. However, the bacteria in the subacute bacterial endocarditis are low virulent bacteria, and the bacteria in the acute bacterial endocarditis are strong bacteria or virulent bacteria. Also, the subacute bacterial endocarditis does not occur on a normal valve. It needs a diseased valve. That's why it always follows rheumatic fever or occurs on a congenital anomaly. But however, in the acute bacterial endocarditis, the vegetation occurs or the infection occurs in normal valves. But the appearance of the vegetation is almost the same. The effects of the vegetations is different. In subacute bacterial endocarditis, the vegetations will cause only infarction. It can also cause petechial hemorrhages. As we said, we can have the flip-bitten kidney, the oslar nodules, the splinter hemorrhage under the nails. All these are effects of the bacteria, of the vegetations, of the emboli of the vegetations that are acting as if they are sterile emboli. In acute bacterial endocarditis, the vegetations contain virulent bacteria. When they detach and cause emboli, they will cause pyemia, and pyemia will reach different organs of the body and cause multiple pyemic abscesses. Here, it's not only infarction, it's infarction with suppurative inflammation and abscess formation, and multiple abscesses. It causes multiple abscesses, and it is a fatal condition.
شكرا دكتور.
طيب. If you wish, we can proceed. We have two options. We can proceed with rest of the cardiovascular subjects and finish in one lecture, or we can stop here and continue in another lecture. What do you prefer?
Another lecture.
So you prefer we stop here and we can continue the next time. Our next time will be respiratory. We go by the sequence: cardiovascular, respiratory, lymph node, cardiovascular, respiratory. We go by this sequence عشان خاطر ندي محاضرة لكل حاجة. If you wish we stop here, we can stop and then we continue the next time. If you wish, we can continue. We don't have a lot of things to share. Can we take a few minutes and then continue? What do you think?
هو دكتور بس الفكرة ان في ناس كتيرة ما حضرتش ومن البداية والدنيا ملخبطة، فلو هنبدأ مثلا موديول تاني يبقى أفضل بدل ما نفضل نكمل حاجة مش عارفينها هي ايه أصلا.
طيب. Okay. We'll stop now. and then the next time we can revise this lecture and then continue with the rest of the subject. And I will try to see how to record the lecture so that we can record it for you, so that you will have it with you. Okay. So we'll stop now. Agreed. خلاص كده موافقين؟
تمام دكتور.
خلاص يبقى احنا كده النهارده we studied rheumatic fever and endocarditis. I wish that you read it, and then if you have any questions next time you can ask me, and as I said we will revise it again so that if someone has not attended the lecture can have an idea about it. Okay, see you next time. Bye bye.